I think the bottom line is to focus on higher risk patients and not the lower risk patients who probably have less to gain. So when we initially started this initiative, and I have to give credit to Jeff Moses in particular, who, by the way, just had his birthday. I'm not going to reveal how old he turned today, but he really is, I think, the godfather of this. Certainly him, Marty, myself, others, we were just talking about this, and many people honestly have done this for their whole career. So this is nothing new to experienced operators. But the idea of sort of identifying it as a specific initiative refers to sort of identify a population that were underused and to shift our thoughts away from overutilization. You know that in the United States we have a lot of concerns about appropriate use criteria. I've even heard that over here, overuse of stents. And the idea here is to focus on people that could truly benefit from our revascularization procedures. It was to raise awareness in the general and specialized community of this high-risk population and to enlist collaborative support not only with our colleagues in interventional cardiology, but colleagues in heart failure, colleagues in general cardiology, even industry partners to sort of get behind something that made sense. We wanted to educate, we wanted to teach, establish best practices for patient selection, for patient treatment, and even post-procedural care, and then importantly, identify research and clinical other initiatives that could help to treat these patients more effectively. So the rule number one is you had to understand the diseases you were treating, and understanding this is very important. I think it sounds very trite for me to say understand the diseases you're treating, but it's important, and the reason it's important is because we actually don't understand it very well. This is a nice slide that's derived from a US registry of patients, where patients are asked, are you having angina? Their physicians are then asked, is your patient having angina? And you would like to think that the correlation between the patient having the symptoms that they express and the physicians identifying those symptoms expressed by the patient ought to be 1-to-1. But it turns out that actually there are many physicians that don't accurately understand whether their patients are having angina, and that may be because they're very busy and they ask, are you having chest pain? The patient says no, and so they say, oh, the patient's fine. But they didn't ask, if you walk from here to the end of the hallway, are you out of breath? Or other questions like that. And so it's important to make sure that you take a good history, because if you can't identify that the patient's actually having symptoms, then how are you going to accurately offer revascularization to these patients? Now, another thing that we see happening is there's variability in care practices. This is a slide from a registry in the United States, the Get With the Guidelines registry, where on the x-axis are plotted hospitals and on the y-axis are plotted how frequently medical therapy is used as the dominant strategy for a patient that has a non-STEMI with left main or three vessels disease seen on the angiogram. You would think that there are some patients, maybe very, very elderly or frail, that really ought to have medical therapy, and that's fine. But on the right of the slide, you see there's some hospitals that treat medically these patients with non-STEMI left main three vessel disease diagnosed at cath 30% of the time. That is way too high, and there's variability because for the exact reason that Ramesh mentioned, people say avoid these patients and don't necessarily treat them because they're too high risk. Finally, one other study that I'll show you, and this was one of our fellows did this analysis with us, basically looking at patients who present with new onset heart failure. They come into the hospital for heart failure for the first time. How frequently do they actually get tested for ischemic etiologies of the heart failure? Because as you know, ischemic etiology is the number one contributor or the number one cause of heart failure, at least in the northern hemisphere. And it turns out that within 90 days, less than 30% of patients actually had a test, and that's a nuclear stress test, a stress echo, an MRI, a CT, or a cath to determine whether they had heart failure of an ischemic etiology. So they just give the patient diuretics, they say you're going to be fine, they say there's no data for revascularization, and then the patient goes on to have further problems. So this underutilization was something that we wanted to address, and that's why we sort of came up with this initiative. So it's funny you asked the question before, because the question is, what is CHIP? And so there's many different acronyms that you can use, and we don't profess to have the perfect acronym, but we initially started with complex, high-risk interventional procedures. We then moved it to complex, high-risk indicated patients, because you needed to have an indication. It wasn't just about the procedure, it's about the patient. And then some people have turned it into complete revascularization of high-risk indicated patients. So no matter what acronym you use, the point is we're looking at high-risk patients that should merit revascularization based upon their symptoms and or their disease, and how can we identify these patients and treat them safely and effectively. And we tried to elucidate this in a white paper that we published in Circulation a couple years ago, and this was a group of a lot of people that contributed to this, but the whole idea was to focus away from low-risk patients who might be managed medically, who might not gain a lot from a procedure, who might actually have a complication from a procedure, and focus on the higher-risk patients who have more to gain. The other aspect of this is that we specifically mentioned in this whole initiative that this is not about PCI. This is about revascularization. If the patient is a good candidate for surgical revascularization, go for surgical revascularization. What this initiative is about is patients who are deemed to basically be candidates for revascularization and then figuring out how best to get that patient revascularized one way or the other. And so we are not anti-surgery at all. Hybrid procedures, pure CABG, they work great in selected patients. This is about revascularization as a whole. So the reason it's about revascularization as a whole is because there are a lot of people out there who say that in stable ischemic heart disease, there's no evidence whatsoever that coronary revascularization improves prognosis. This is the prevailing wisdom that's out there. If you read the papers, you read the New York Times, papers worldwide, they basically say that the reason to treat patients with coronary disease is for their symptoms and their symptoms alone. Well, first, if you talk about symptoms, it's pretty clear that if you focus on patients with severe symptoms, this is data from the FREEDOM trial, same exact results shown from the Syntax trial, same exact results shown from the STITCH trial, same exact results shown from a host of trials, their quality of life improves with coronary revascularization, and it's basically similar if you do surgery or PCI. So high-risk patients, lots of symptoms, do better with coronary revascularization. This is just a letter that I got from a patient who had a severe disease, low EF, and a CTO of the LAD. They send you messages like this: I thank you for all of your help. It's a great feeling to be angina-free. Typically speaking, especially in the modern age when people SMS you, it's really nice to get a written letter like this, and these patients really genuinely have improvements in their lives and they're very thankful to you for it. Now, beyond symptoms though, it's very important to remember that coronary revascularization of high-risk anatomy is associated with improved prognosis, mortality, and otherwise. So this is just a slide from the ACC/AHA guidelines that essentially looks at the extent of coronary disease and what the actuarial 5-year survival is, assuming medical therapy only. So on the right of the slide is the 5-year survival. You can see as the disease gets worse and worse, 5-year survival starts getting around 65% or less. That's a problem, especially if you're a young individual. And so in these types of cases, this is where coronary revascularization shines. We know that this is the case from left main studies. This is the most recent data from STITCH, the STITCH's extension trial, showing that even though there's an upfront mortality risk with coronary artery bypass grafting, if you revascularize these patients over time, you save lives with a number needed to treat of 14. So that concept is imbued in the whole CHIP premise that for high-risk patients, we can improve not only symptoms, but also prognosis. Ramesh showed you this slide. I'm not going to go through it in detail other than to say that we define who these patients are. There are a variety of ways, and it doesn't mean that you're a CHIP patient if you have one of these. The other thing that's important is CHIP is not about a particular device either. It's not just, oh, I used an Impella, therefore it's a CHIP case. There are a whole host of things that go into these types of cases. It's more of a mindset, and hopefully I've set the stage of that for you, and this will hopefully be covered in other talks as well. Really, the other aspect is making sure you're properly trained. And here, if you see, this was at our holiday party. Everybody's having a good time. These are the valve fellows in the top right. The endovascular fellows are here. The only one with the eye on the prize is the CHIP fellow in the bottom. He remains focused despite all the calm, and he's one of our fellows currently at Columbia who's finishing. Now, in terms of what you need to know, there's a lot of things, and so we elucidated this in the manuscript. You need to know how to treat all these different lesion subsets. There are a lot of devices, there's a lot of techniques, and it really takes dedicated efforts in order to do it. Dedicated efforts also pay off because there are volume outcomes relationships that can be demonstrated in these higher risk populations. This is data from China. Same center, Fuwai Hospital, the most busy PCI center in the world. At the exact same center, a high volume operator treating a left main has better outcomes than a low volume operator treating a left main. Even shown in a randomized fashion, but at least we get better and closer to it, because let's face it, surgery is the gold standard. And if we want to come close to it, we need to do everything we can in order to match it. So just a few final thoughts. The fundamental of the CHIP mindset is that the clinical indications for the case don't change just because the lesions are harder to treat. If somebody is very symptomatic and you think they need revascularization, and then you look at the angiogram and it looks scary, the patient's symptoms don't go away. You're offering them medical therapy because you can't treat the angiogram. The reality is that you need to either learn how to treat it or refer the patient to somebody who can. One thing that's very important is not to just embark on treating something that you don't know how to do, because you're going to cause more harm in that situation. This is very well illustrated in the Syntax trial. This is a nice slide from the trial I like to show, that at each individual site is a dot or a bubble on the graph, and the size of the bubble is based on how many patients they randomized in the trial. This white dot on the right side is a site that had a MACE rate in the cabbage arm that was 40% and PCI only 10%. The red dot on the top left here is a site that had no MACE in the cabbage arm and a 50% rate of MACE in the PCI arm. If you're a patient and you're at this site, what do you want? Do you want CHIP PCI or do you want cabbage? Similarly, if you're at this site, what do you want? Do you want cabbage or do you want CHIP PCI? The bottom line is, unless we're humble and know our own limitations and strengths, if we just try to indiscriminately apply what I'm saying to all of our patients, we're going to cause problems. And so you have to be very, very circumspect about it and then offer the patients the best options. We have a number of courses, as many of you are familiar with, that we try to teach some of these concepts. Additionally, we've outlined a number of research priorities, because this is not just a concept that makes sense and we just want to go with it. We actually need to show that these things can actually work. And I'm not going to go through these in detail other than to say that we illustrated them in this manuscript. There are a number of trials that come out and studies that come out that are very informative. This is a study from our former fellow looking at collateral channels and CTOs, what's safe, what's not safe, what are the most common things. Similarly, trials like the Excel trial, Ultimate CHIP trial, surgery versus PCI for left main disease. Left main disease is a CHIP type of patient subset. We're running the Eclipse trial. This is a trial of atherectomy versus conventional angioplasty for patients with severe calcified coronary arteries. Ashish mentioned the Optimum trial yesterday. This is a study looking at quality of life among these patients that are surgical turndowns to see how they feel. And then there are other studies in the UK. They're doing a trial called Revive, which is basically ischemic cardiomyopathy. It's like Stitch, but with PCI. Ischemic cardiomyopathy, medical therapy alone versus PCI plus medical therapy. So just to conclude, the basic CHIP premise is that there is a large underserved patient population that can benefit from coronary revascularization, rather than focusing on low-risk patients who could be easier to treat. It's very easy to treat a type A lesion, but is that patient really helped relative to some of the other disease that we've seen here at this meeting? Those have more to gain. We're going to see more and more of these patients as the healthcare system evolves, and we have to develop ourselves comprehensively with not only advanced technical skills, but also cognitive skills to be able to understand these patients and to treat them effectively, and that's what's sorely needed. So we've had a good start, as this is the Freedom Tower being put up, but there's definitely still more room to go. Thanks so much.